Okay, well, thank you, everybody. This is Allie Orwig with the Indiana Rural Health Association. We're very happy to have you with us today. We've got a really great presentation for you all. Just as a quick reminder, we do ask that you mute your line if you're not speaking. It does help with the flow of the presentation. If you have any questions during the presentation, you can use the chat function at the bottom to submit any questions you might have. But without further ado, I think that's all of the items I have. We'll go ahead and Ron, you can take it away.
All right, thank you very much. So first of all, I just want to thank everyone for taking times out of your busy schedules to join us today to talk about something I'm really passionate about, which is telehealth. And first of all, I'll just give a little bit of my background so you understand the different angles we can take and what we're going to talk about today. So I actually, started out on the industry side. I used to run a large telemedicine network up in the northeastern U.S., up in the state of Maine. I have my bachelor's degree in nursing, and in Maine, we faced a lot of the same rural challenges that a lot of you folks do. We have very rural areas. Sometimes we don't have primary care. We even have islands off the coast of Maine where we set up telemedicine. And we developed a network of about 350 sites. And this was quite a few years ago when, there was really no reimbursement. There was Medicare would pay for like 80% of a consult, and then the specialist was supposed to split it with the rural doctor, with the primary care doctor. So we've come a long ways, right? And we're going to talk about that. Then from there, I actually moved on. And when I was at Maine Telemedicine, we did consulting. So I did consulting with a lot of different organizations for telehealth. And then I joined a corporation where I had the opportunity and privilege to travel around the world, and not just doing telemedicine in the U.S. and remote areas, but also having an opportunity to look at it from a global perspective. I traveled 46 countries in about 5 years. I worked with a lot of private organizations and a lot of public, which I think sort of helped my mindset a little bit as we look at sort of capitated rates and some of the different payment models and different things we're going to talk about with telehealth today. I was on the board of the American Telemedicine Association, and I was also on the policy committee. So today during this presentation, we're going to talk about the impact that telehealth can have and some of the best practice models. And what's most important for those of you that are new to this are the consideration points and things you need to think about as you develop your program. So this program is developed for a variety of different levels of experience. Some of it's very basic for some of you that are this is your first exposure. Some of it's more complex, more in-depth for some of you that have been in telehealth for a while. All right, and I can relate. We talk about rural. The organization we started this out of is called the Regional Medical Center at Lubec, which is in Lubec, Maine, which is actually the easternmost point on the continental United States, and it's very, very rural where we started telehealth. So with that, I'll begin my presentation. So, I think what's important is first of all, we just need to look at where healthcare has been, and these are numbers and that a lot of you are like, okay, we've seen these things a million times. But I think what's important is, we're seeing this sort of transformation in healthcare. And, one of the reasons is that we found that healthcare really is, it's vulnerable to disruption. So if you don't have healthcare reform, healthcare sort of has trended with other, and even greater so in some instances, other market stressors. So from 1960 to 2010, from this McKinsey report, the cost of healthcare in the U.S. increased 5 times gross domestic product. Now, I think a lot of us that have been in healthcare for a while, we can relate. But the interesting thing is you look at this slide is, and another reason why telehealth, and we're looking at different delivery models and different ways of providing care, is that during that same time, according to this report, we actually decreased productivity. Now, when they talk about productivity in this report, it's not about, of course we have different technologies, we have diagnostic capabilities, those type of things. What it's about is the process of the way we provide healthcare. But we also, right, in the healthcare field. So what does that bring us down to? What it brings us down to is we're having a shift, as all you folks are caught in the middle of, and we're very familiar, and why a lot of you are here, is we have this shift of not just focusing on fee-for-service, let's wait until somebody basically becomes sick or they have issues and then we try to fix them. We're moving more towards quality-based care, always care, or some people call it population-based healthcare, and we're moving away from just pure fee-for-service models in some levels. A lot of you, of course, a lot of folks are still doing that, but we're moving more towards population health. And why telehealth is so important and why we're having this discussion today for those of you that are in rural communities. And we're not just going to talk about the clinical side of it, we're going to talk about the business side of it, right? What are the business development drivers that you need to consider when you're looking at developing your program? And I'll talk about that but we do know there's a correlation between quality of care and access to care. I think we'd all agree upon that at face value, right? There's definitely a correlation to those things. So why organizations are looking at telehealth is they're looking at how they can develop more touch points regardless of a patient's location, to help us as we make this shift away from just fee-for-service, and we're moving more towards population-based health, capitated rates, monthly fees. You know, we're talking about ACOs and all of the other things, and we'll talk more about that and how it fits up. So first of all, and the chart on the left is really about, you know, we don't think about this, but as we look at different touch points and how to reach people, a lot of you are in, you know, let's say FQACs, rural health centers, critical care access hospitals, if you're on the rural side of this discussion. You know, we're looking at, you know, about 77% of the time people spend, if you're 24 to 54, we spend time in two places, which is at work and at home. And the two places we can't receive healthcare now is at work and at home. So we're looking at different models to touch people. So we're going to dig a little bit deeper in that. And as the incentives change, which they are, as we move more towards quality-based care and reimbursement change how you're incentivized, we need to change our delivery models and look at different ways that we do business so that we can increase these efficiencies, as we showed in the previous slide. Now, for some of you that are very new to telemedicine, you'll hear two different terms. You're going to hear telehealth, which is sort of a blanket term, which means the transfer of electronic medical data in general. Now, these definitions can be a little bit debatable depending on who you're talking to, but it's basically the transfer of electronic medical data from one location to the other. Is sort of the telehealth definition. That can mean PACS, electronic health records. It could mean store and forward, where you take a snapshot of a lesion and you send it to somebody on the other side. It could mean remote patient monitoring. All of these different forms of virtual care, right? Telemedicine has sort of been niched a little more, and if you go to the next level down, in most healthcare telehealth circles, it usually means more of a direct contact between a clinician and a patient, right? That direct interaction. And as I say, those definitions can move a little bit based on who you're talking to, but for today, let's use that as the basis of our discussion. So, you know, we talk about different types of telemedicine. I gave sort of an overview of telehealth. Let's talk about the direct contact piece so we don't try to, you know, bite off too much today on the different things. So first of all, let's talk about diagnostic telemedicine. When you think of diagnostic telemedicine, this is where, you know, more facility-based inside of healthcare organizations. So for those of you that are sitting inside of a rural hospital, like I say, federally qualified health center, FQHCs, rural physicians offices, rural skilled nursing facilities, you know, all of these different organizations. This is about diagnostic capabilities. And what we want to do with this on the left-hand side with telemedicine carts and such is we want to provide and meet the gold standard. We want to have the intent and provide the same level of care from a clinical efficacy perspective as if the patient was in the room with a clinician, okay? Now, for some of you that are new to this side of telehealth, we can do a lot with the technology now. It's come so far in the last 10 or 15 years. You can hook in over 40 different medical devices into these carts. You can do 12 EKGs. You can do ultrasounds, you know, level 1 ultrasounds. You can do spirometry, breathing tests, you know, all the general scopes, heart and lung sounds. You can do, you know, for women's health, you can do vaginal ultrasounds. You have colposcopes. We can do ophthalmoscopes. What I'm getting at is everything besides allowing the clinician to touch the patient, you would have a nurse with the patient or a healthcare professional with the patient. We can do those things from a distance, and that's the intent. And we're going to talk about that piece of it, diagnostic telemedicine, okay? How you can increase access to specific clinical services at the level that we just talked about from a clinical perspective. And then also, of course, you know, you have full integration into taking these systems into your electronic health records. So we're trying to mimic what healthcare professionals do on a day-to-day basis in their traditional workflow, which is important, which is what we didn't have in the past, okay? And we all know the issue with health records talking to one another and all that stuff. So those things are being addressed. Now, another big movement we're seeing is the direct-to-consumer side. And what this is, and this is all about intent, and we'll dig deeper into this. This is about where you can be on your phone, you can be on your device, and you can actually talk to a clinician, right? And, there are organizations out there doing it. We're going to talk about some of the business of healthcare and the drivers of telehealth, the business drivers, and what those things consist of. But this is where basically someone has an ailment or a situation, and they basically get on and you can talk to a provider. There are organizations that are doing this from a distance now that aren't affiliated with your healthcare organization. And then we see many more healthcare organizations themselves actually developing these sort of tools where their patients can actually access their physicians in their regional area. Okay, so diagnostic telemedicine and direct-to-consumer. And they're taking this direct-to-consumer so serious as we talk about some of the changes. Right now, there's legislation that was just put in to expand telehealth that next year, they're looking at having, for Medicare patients, looking at having where you can expand and a clinician can actually get $14 for providing a virtual visit over this type of technology. Now, part of that is, of course, Medicare wants to decrease unnecessary inpatient settings or inpatient visits. And studies have shown that sometimes up to 71% are unnecessary, that people could manage these type of things. And they want to, of course, stop exacerbation of clinical conditions. And then they also don't want people going to the emergency department. And from a clinician side, from your side, what's in it from you? And this is debatable. If a patient comes through the door, you bill for the full amount. But if you do it over this, you get $14. How much will you be able to do and actually get some of those fees for? The $14 rather than making phone calls now that you're not getting anything for, right, under the current fee-for-service model. So those are sort of the two types of telehealth we're going to talk about today. Now, kind of to the meat of the discussion. So, having done this, I've been doing this for, it's been 22 years, I guess. When I think about it, it's been about 22 years I've been in telehealth. And, when I started out as a nurse on the remote patient end with the patient, presenting the patient. And then I worked my way up to executive director of a telehealth network where I was out, working to develop policy and regulatory and all of the other things and try to get new sites and even in my state or doing consulting for other states. And I've always thought, I'm like, what are the three things that I always get challenged on? Like, what do I have to prove to different people within a healthcare system? And this will include for you in a rural health, and we're going to specifically focus on that for the focus of the presentation. But there's three things. I always get questioned to patients like this, right? That's where we're in healthcare. I'm a nurse. We have clinicians on the other end, administrators. We're all in healthcare because we want to help and take care of patients, right? We went into it for a reason, clinicians. So the patients like what we're doing. And then there's also the business side of it too, is do they like what we're doing? We want to make them happy because we're in medicine for that reason, but also because we don't want them to go someplace else. That's just the reality of healthcare, right? And we're going to dig deeper into that, what patients' responses to telehealth, the different forms I talked about. The next question you're going to have to prove, and you're going to get challenged on it, as we have some clinicians on this call, and we have to prove, is clinical efficacy. Can we provide quality care via telemedicine? Which is, because it's the clinician's license who's on the line. And that's one piece of it. But also, we want to just, of course, provide good clinical care from a healthcare organization perspective. So we're going to get challenged on that. And I'm going to talk about the data we have on that shows clinical efficacy in telehealth. And a lot of that is tied to intent. Okay. When I say intent, I talked about diagnostic telemedicine. That's why I showed you that. Yes, we want to be able to provide and do as much as we can as if the patient's in the room with us and meet that gold standard, right? But then there's direct-to-consumer, which is another model we're seeing. And what's the intent of that? What's the intent of your program? Is it to basically just take care of those things that you do not need objective data? Like if someone has a sore throat, they need a throat swab, or maybe they have maybe their symptoms mimic what you might think might be a urinary tract infection, and you're like, you know what, you need to come in. I just don't want to put you on antibiotics because you need to get we need to do some additional tests, right? So clinical efficacy revolves around that, and we're going to talk about that, what some of the research and studies show. And then this is the big one. The first two, I'm going to spend quite a bit of time on ROI and the business case of telehealth, okay, and why organizations, so you can start putting your head around that. Because as you're going to see in the data, patient satisfaction, I don't want to give it away because I have some slides on this, but it's there. That's not the issue. Clinical efficacy. lot of good, there's a lot of studies out there, and there's a lot of comparison studies from diagnostic perspectives. Some of them aren't as longitudinal, but we have good data. The part that most organizations are struggling with, and why a lot of you are on this call, is looking at the business side of telehealth and how do you justify it? How do we increase access to care, provide better care for our patients? But if we're going to do that, right, the bottom line is we all still have a bottom line, and we're going to talk about that in depth. Those are the three things that when you think about your program and developing it, regardless if you're sitting here right now and you're in a bigger facility that's going to be providing services, or if you're in a smaller facility in a rural area that's going to be receiving the services, you need to consider, okay? So let's go through this part a little bit rather quick, because I want to have some time at the end for discussion and questions. You know, this is something, honestly, we've just beat to death, is patient satisfaction. When I started doing this 20 years ago in Maine, we got a grant from the Office for Advancement of Telemedicine going way back. We did study after study and questionnaire after questionnaire. And this is when the technology wasn't nearly as good as what it is now, and the quality wasn't as good. And every study I was personally involved with, and if you look at the literature, patient satisfaction levels are almost always above 90% for high satisfaction. So patients like telemedicine. They like the convenience, the interaction process, what they take. Patients like telemedicine. I think there's just lots of, we're way past that. There's a lot out there. And of course, you know, that is based on that you're using the right technology, you're providing a good experience for them, all the things that we would just assume, right? Clinician satisfaction rates are a little bit lower, but they're still satisfactory. Generally, you know, they're above 86% for good to high levels of satisfactory, right? So clinicians like it, okay? So those really have not been the issue. A lot of it's aligning the incentive for clinicians and for others. And we'll talk more about that from a clinical perspective. But if you have a specialist who's booked out for 6 months and you say, hey, I have this really cool technology, you can see more patients, they don't really get excited, right? But we're going to talk about some different models, how maybe they're going out and doing a clinic now and they're driving 2 or 3 hours, and we can help them do what they have to do today, but they can do that more effectively and efficiently and provide more care to patients, and also benefit them from a business perspective. But like I say, as would be expected, there are factors that determine satisfaction rates, such as technology use, clinical presentation, all those other things. So that's enough on that side. The next slide is clinical efficacy. You know, if you look at a lot of the research and data, you know, there's a lot of comparison studies, and a lot of them like in mental health, and then we'll talk a little bit about like telestroke and some of the other key applications. But there's larger amounts of research literature in telemental health where they would show that if a mental health professional sees a patient over telemedicine or video technology, and then they basically make a diagnosis and they disconnect the call. If another clinician walks in the room and sees me in person, that really the variance in what the diagnosis is really no different than if you actually saw the patient, than if they both saw the patient in person, all right? And it's interesting to know, I know a psychiatrist that's actually a friend of mine, and you know, he's like, yeah, you know, he goes, when I went for my, you know, my test and my boards, I mean, they basically put in recordings on a TV, and I watch different clinical presentations, and that's part of how I become certified as a clinician, as a psychiatrist, right? So, you know, visual, they feel like they can get it. So basically, they show that the diagnosis is the same. We do have some studies that are starting to get a little bit more longitudinal, which we all need, is what is the effect of telehealth over the long run if a patient is just seeing a healthcare professional over telemedicine. And then there are some other ones for like stroke that show, there was one in California, University of San Diego, that basically showed if, you know, when we think of stroke, right, we're all very familiar with emergency room, someone presents, there's 2 types of stroke. There's an ischemic stroke, which is where we have a blockage, and then there's a hemorrhagic stroke where we have a bleed. A lot of you already know this, but we know that there's a very crucial time window, right? You know, 3 hours, 4 hours, depending on what part of the world you're in. And what they showed is traditionally the way that it would work is that the emergency room doctor would call the vascular neurologist. The neurologist would get the CAT scan, they would get the imaging, and then the emergency room clinician would basically assess the patient, and they would talk, and then they would make a decision if the emergency room physician would do it. It was if they're comfortable with running TPA, right, clot busters. One of the studies showed that about 80-something% of the time they felt like the right decision was made with just the phone call, but when the actual vascular neurologist could actually assess a patient and apply the NIH stroke scale to that, patient that they felt comfortable that they were making the right decision about 98% of the time. All right, so there is some good data out there that shows in certain specialty areas we have more data. Clinical efficacy, honestly, really is not as big of an issue with diagnostic telemedicine. We're past that. The biggest thing is when you look at like direct to consumer, what is your intent? What are you trying to do? And do you have a proper referral pathway if it cannot be managed over telehealth? Because if it can't, then, you know, one of the other sides that state medical boards are concerned about is, are we just prescribing antibiotics for everything if we don't know what it is, if we can't do the throat swab and collect objective data, if we can't do the urinalysis, right? So clinical efficacy, depending on your intent, is important. Now, like I say, those other 2 points were a long ways down the road on them. Lots of very successful telemedicine programs doing thousands, 100,000s of consults, right? The next question, though, that a lot of folks are struggling with, and this is where most of our conversation is going to take place today. So what are the business drivers of telehealth for you as rural healthcare professionals, right? And why are healthcare organizations invested in telehealth? So we're going to look at this from both sides, because even if you're on the rural side today, you're going to need to be able to engage and get those bigger organizations, the centers of excellence, the tertiary care centers that actually have the specialists to provide clinical services, or the facility with the specialist, right, a physician group. So there's really kind of 3 buckets here that I put it in. So when we look at the cost of healthcare, there's sort of 2 levels, right? There's the bigger discussion, does telemedicine help decrease the cost of healthcare for the overall healthcare system, right? That's one discussion and one argument. You know, does it help bring down that 20% of gross domestic product, little over $3 trillion a year that we spend on healthcare, that overall number. But then there's also the other piece that you're concerned about on your individual day-to-day basis. How does healthcare affect you, or how does telehealth affect you from a financial perspective, and what are the things to consider? So let's talk about it at that level. The first thing that healthcare organizations are doing from a rural perspective, and even from the larger healthcare organizations, is how do we meet the new mandates and payment models? I think we'd all agree that we're seeing a movement away from just pure fee-for-service. We're moving more towards quality-based care and capitated rates. And if they're just giving somebody a chunk of money and saying, here, it's your responsibility, or a global fee for a surgery. We did a program with a hospital in the past where they would get a certain amount of money for a surgery, one lump fee, a global fee, and they're like, take care of the patient. So when the patient's discharged, they were using telemedicine in their homes as a way to do a follow-up, so they don't have an unnecessary readmission where they have to basically eat that cost for a full readmission, right? To meet new mandates and payment models. So capitated rates, accountable care, quality-based care, it's all moving those directions. How do we meet those new mandates? Now, to give some examples of that, one example is what I just used. If we have global fees, how do we reach out to patients, and how do we enable them to be more self-sufficient in the rural communities and provide care where they don't have to come in for inpatient services, which is, you know, we went way past the other line where things exacerbate and get bad, or we can even avoid unnecessary office visits, right? Those type of things. And then the next thing is increased market share. Now, this is one of the big ones. So let's talk about it from a business perspective from both sides. If you're an organization on here that is providing clinical services, and why you should be interested in these rural facilities from a telehealth perspective, when you look at increase in market share, and it's about how we can retain current and get new patients, right? And I see this quite often when I meet with healthcare organizations. Of course, we want to do a good thing. We're reaching out. We're increasing access to care. We're doing good things, and the patients end up benefiting. But when you're on the hospital side of it, a lot of times what they want to do is they want to use telemedicine as a way to reach out and develop services or relationships with an organization, so that when that patient cannot be managed in that rural facility, they refer them to their facility instead of their competitor, who might be up the road. Okay, and we're going to talk about that a little bit more in my next slide from the business perspective. All right, so it's about increasing market share. And there was a study by UC Davis that actually showed this, that I'm going to show in my next slide. But basically, they go to them, they don't go to their competition, and they can generate more revenue. And for those of you that are in hospitals, you know that on average, about 60 to 80%, depending on which facility it is, your revenue just doesn't come from doctors seeing patients. It comes from ancillary services, x-rays, MRIs, CAT scans, lab tests, and then of course inpatient stays. The average Medicare billing stay, I think, is around $54,000. So those are the real revenue drivers. So how do we have those relationships and capture and increase, healthcare market share by utilizing telehealth? And that's one of the big benefits of it. Okay. On this side of it, it's the same thing. The direct-to-consumer piece. And that's why organizations are doing it. It's becoming more consumer driven, more convenience for patients, and to be able to connect to your facility and at least initiate that conversation from a clinical perspective helps drive that revenue from other things. Now, let's talk about the other side for those of you that are on the rural side of this and why are organizations utilizing telehealth. I think for those of you on the rural side, we hear it all the time. We make the referral and we just lose the patient. They're gone. Right? That happens a lot in Maine. They make the referral to the specialist or the bigger hospital and we don't ever see anything from the patient. So there's kind of that nice intermediate here of how organizations, the larger facilities, can use that to capture market share and develop those relationships and capture patients that they otherwise wouldn't get. But then from the smaller facility side, this is where you keep the patient in your local community, that they can use your pharmacy in-house or they can use a local pharmacy. You do the lab draws. You do all of those things and you manage the patient internally. And then the other thing is when you look at, and I'll talk about this later, as a delivery model, it helps make more efficient use sometimes of specialty care because they do it on a consultative basis where the specialist is providing the consultation, the patients in the rural area with their primary care provider, but they're doing it on a consultative basis where the primary care provider is actually still the one managing the patient, right? So it's a more efficient use of some of the valued specialty services when appropriate. That we need. Now, decreased cost. How do we increase efficiencies within a system? And this is one we get quite frequently. And I think a lot of you can relate to this. If you're in a hospital system right now, you have physicians, clinicians that are salaried and you're paying them so much an hour, and we're doing rural outreach to a lot of the organizations that are out here and they drive 3 hours or 2 hours or an hour and a half, and we're paying them that salary. And a lot of times just economically, it doesn't work out if they're driving a couple hours to a rural area with traffic and they're providing clinical services for a clinic, like a 2-hour or 3-hour clinic, and then they're driving back, right? So from a financial perspective, to try to maintain that relationship and support your organizations within your facility, we're seeing organizations are beginning to move to telehealth on this. One thing is they can increase efficiency. They can see patients that whole time they're driving. They can increase revenue. That way, we're not paying them for non-productive sort of windshield time. The other thing is that we can see more patients in the rural area. We can become more productive, right? So we're helping the rural facilities as well from a distance. Now, it's one of the interesting things when I've done telemedicine over the years. We always talk about all of the the new applications and the fancy things, what can we do new? Don't always look at telemedicine as adding new services. Sometimes look at how we can continue to provide the services that we're doing now. Maybe the perfect example is we have specialists coming out for a clinic. How can we utilize telemedicine to just increase efficiencies and do what we're doing, but maybe provide more clinics? Maybe instead of just providing a clinic for 3 hours, we can do it for 6 hours if the patient load dictates. Or maybe we can do it more ad hoc and we can just schedule patients into our schedule rather than, people don't always get sick once every 2 weeks when we need to see them, right? So maybe we can catch those folks in between so they don't have those issues. So one of the studies I talked about, just a little bit of data on this. Now, this is an area that we don't have as much information because most organizations that are doing real well with telehealth, they don't really publicize this because they don't want everyone to know that they're using telehealth for increased revenue. But one study that's out there is UC Davis. They did 143 pre-telemedicine, 285 post-telemedicine. You can see it. They increased the revenue from $2.4 million to $4 million per year with a specific population. And you can see the specific billing for the professionals, right? So it went up and it almost doubled, right? So that's one example by increasing market share and contacts, how they can become more efficient and also decreasing that windshield time. Decreased cost, a big one. Now, for those of you that are, we have a lot of different organizations, rural, but we have rural jails out there and we have prisons that are in rural areas. So don't just always think of telemedicine as facilities, but also the services that you provide. One of the biggest areas and some of the most successful programs are within prison systems. One of those is if you look at the University of Texas Medical Branch, they have a $500 million a year contract with the state of Texas Department of Corrections to provide all the clinical care for the 100 and something odd thousand inmates that they have, right? And over 10 years' time, and it's quite the system they have down there. They have doctors in rooms at their telemedicine workstations, and all day they provide telemedicine to inmates all across the state. And as we all know, it's a huge state. They put a report out a few years ago that was public, that they believe that they saved over $1 billion by the use of telemedicine and the electronic health record associated with it, from all the costs and all the travel and everything else, and then, of course, decreasing the security risk. Reduce hospitalizations underneath capitated rates, population-based health, and we talked about the efficiencies, okay? Now let's dig a little bit, the most common specialty, most common medical specialties. I think most telemedicine programs, just take a second to think about that one. If you had to take a guess on which ones are on here, which one would you think would be the most most utilized clinical application? Just take a look. And some of this is a little bit anecdotal, but if you talk to different organizations and the organizations that we've provided services, one of the biggest ones, of course, across the board is behavioral mental health. That's a big one. There's some very programs. We are seeing significant growth. We talked about neurology, telestroke, dermatology, but we're even seeing some big pushes in primary care to some of these rural areas that are the next level of rural, right? We're seeing primary care. Emergency cardiology. One of the biggest advances in telemedicine, and why it's important too in these rural areas, is that before it was really about video conferencing, right? And then you plug visual devices into it. And that's still a very important component, but telehealth has expanded where it's about not just the visual component, but it's about all the diagnostic capabilities and tests that you can easily integrate into this technology and immediately send to the healthcare professional or specialist on the other side. All right, so it really runs the gamut of what we're seeing from a clinical perspective. Now let's switch gears a little bit and let's talk a little bit more in depth about where we're at. I know there's folks on here that are new, and I know there's some folks that are here that have been for a while, but let's talk about telehealth regulatory policy reimbursement, which would include state licensure, and then some other key policy things like, when your clinicians ask you, it might increase liability for doing telemedicine. So when you talk about reimbursement, the first thing is, boy, it's so much better than it used to be. When people say it's hard now, it's not always easy, and there's some certain criteria, and I'm going to go over some of that. But compared to the way it used to be, in a lot of situations, it's actually robust enough that we can really develop, especially the folks on the rural end of this, because everything in telehealth is dictated by where the patient is physically located during the time of the encounter. Okay, that's called the originating site. All right, so when you think of billing, when you think of reimbursement, when you think of state licensure, that's very important, where the patient is located. Okay, so first of all, Medicare. Medicare, as we all know, we're healthcare people, is a federal program. Medicare reimburses in all states, but there is criteria. Okay, now I'm just going to do this off the top of my head. So for those of you that are really well versed in this, if I forget something, throw out a reminder. But first of all, the patient has to be physically located in a non-metropolitan statistical area, right? Or they have to be in a HIPSA. So that's the first thing. Now there's some exceptions to that, like with previous grants and things, right? That's the first thing. The other thing is it has to be a live video encounter. Now we're talking about diagnostic telemedicine. Remember the two different types that I showed you? It has to be diagnostic telemedicine. All right. So you have to be able to see the patient over a live video encounter, and the patient has to be located physically in a non-metropolitan city or a HIPSA, basically not in a city. So for the rural folks, this is all great. The other piece of this is that they have to physically be located inside of an FQHC, a healthcare clinic, a physician's office, a skilled nursing facility, a hospital, a critical care access hospital, outpatient mental health center, inpatient renal dialysis. Those are the main ones. And there was one place I didn't mention there, and everyone noticed it, I'm sure, which is inside of the home, right? So you can't be in the home right now, but there is that legislation, or at least it was proposed legislation, that's being written in for the expansion of telehealth, which will allow clinicians to maybe do that visit for that $14 to see if they need to come in or not, and what we can manage over a virtual visit. The other thing is there's certain clinicians that can provide services, and I'll just hit the main ones. Of course, physicians, physician's assistants, nurse practitioners, So mid-levels, LCSW, psychologists, dietitians, it's kind of all there. And I'm happy to share all this information with you. And we also have one of the telehealth resource centers who's part of this, who of course knows this stuff stone cold. Medicaid, of course, Medicaid's a state program, right? We all know that. Right now, there are actually 49, and this changes, right? Because it's a state and you got to keep track of each state, but there are 49 states that reimburse for telemedicine. There's two ways you can get reimbursement for a state, right? One is that you can just do it through policy. The Department of Health and Human Services in that state can make it a policy to reimburse for telehealth for their Medicaid program. Or the other is you can get a legislative mandate. You can go basically to the legislature and say, I want you to put a bill in, and they pass a law basically that telehealth has to be reimbursed. Now, if you look at that, there are 38 states, and like I say, if this has changed one or two since I did this, I don't think it has, but you never know. I know like Massachusetts is in the process of developing theirs. There are legislative mandates, and with those legislative mandates, there's parity laws with a lot of those, right? And the parity laws are basically, they say, hey, you have to provide clinical services, and it applies to Medicaid, and a lot of times it applies to the privates. Right? So you have to look at each state. But now there's two pieces to that. There's parity laws where they have to reimburse just as if clinical services were being provided in person, right? That's one piece of it. But one thing you want to make sure you check on is when you look at the parity laws, make sure and look at the payment parity, okay? Make sure that's something that a lot of people aren't familiar with. There's parity laws as far as providing services, but then look and see that insurance company or what the laws are and what they provide for payment parity as well, okay? And then we talked about the federal legislature to cover direct-to-consumer. So that's a very down and dirty, really quick overview on sort of a good old telehealth 101, okay? So telemedicine reimbursement is out there. The rural facilities on this call, Medicare reimburses. Most states, Medicaid's not an issue. You just have to meet that criteria of that live interaction in diagnostic telemedicine. The direct-to-consumer stuff is a whole different case. A lot of that is either insurance companies are providing it and you contract with the insurance company, or it's an out-of-pocket expense, right? That people are willing to pay for the convenience of not having to come in. State licensure. Now, I'm going to talk standard, and then I'll talk about there's some exceptions, and we can dig into that. Basically, as I said, think of the originating site where the physician is located. So in Indiana right now, for those of you that are there, if a patient is physically located in Indiana and a doctor is sitting next to me right now in the state of Maine, but they're licensed in Indiana, do you think that doctor can see that patient legally? So if the doctor's in Maine sitting next to me and the patient's in Indiana and that doctor's licensed in Indiana, do you think there's any issues with that doctor seeing the patient? The answer is no. Basically, it's about the originating site. So if that clinician is licensed in the state, now there are some, you got to look at each state, there might be some different laws and different things that basically say, you have to do one in-person visit first. But in general, these are rules of thumb that you need to look at that, no, there's usually not an issue. It's where the patient is physically located during the time of the counter that the clinician is held to that standard. So if they're licensed in the state of Indiana, then the doctor has to be, if the patient is physically located in Indiana, in Maine, then the doctor has to be licensed in Maine to see that patient. But it's usually, in almost all instances I've seen, there's very few to almost none that I have run across, but that the doctor is fine to see that patient, okay? So that's good for telehealth. Just make sure that the doctor is licensed in the state where your patients are. So if you get out-of-state resources, now there are some exceptions to that. There's some reciprocity or from cross-state licensure agreements that have happened, and that's a lot deeper discussion for what we have time for today. But there are some exceptions to that where there's some agreements between states for reciprocity where they will accept another state's license to certain levels, okay? Policy, key points to know, some of the things you'll get questions and challenged on. I talked about the three things about, patient satisfaction, clinical efficacy. We're good there. The business case, it just varies with every organization, so you need to look at your own based on the criteria I gave. Key points to know from a policy perspective is, am I at increased liability if I use telemedicine, right? That's a question you're going to get by clinicians all the time. And I think a gentleman who's no longer with us, his name was Bob Waters, and he's the founder of the Center for Telehealth and eHealth Law, was a real friend of telehealth back in the day. And, I think I like the way that he put it. His exact words were that if you provide care as a competent physician would in the same given clinical situation, you are not at increased risk if you use telemedicine, okay? So what he's saying is, just like in general practice with the clinicians on here, if you provide care and all the 10 other clinicians look at that same clinical situation and say, I would have done the same thing, then, you know, you're probably okay. But that doesn't mean in the court of law that a lawyer might try to spin it and say, because we did this over telemedicine, there might be some spin. And that's his exact words, not mine, to say it. So the reality is, are you really at increased risk? Not really, but it doesn't mean that someone couldn't try to turn it. As it becomes more mainstream, we were less and less. But I think the good news to everyone out here is, you know, we're in 98 countries. We've been around for 27 years, A&B Global Telemedicine. The previous organization that I headed up their healthcare, we had thousands of installs. And I can honestly say I can only think of one case of litigation in telehealth that I was aware of, that I was actually made aware of with one of our customers. So it's really doesn't happen, and it's really been a non-issue, I think, as everybody's saying. It was interesting in the prison system. I even asked them, I said, do you get more suits against you over telemedicine than you did than when you were in person? And it was interesting. The director told me that it's actually the opposite, is that they've actually had fewer issues with inmates in some of these bigger programs. And the one I'm talking about is Texas, this was a few years ago. So one other thing I do want to talk about, and for somehow it's not in the slide. I apologize. I thought I put the slide in, but it's different delivery models. So for some of you that are in rural areas and you're looking at, so how do I work with the bigger hospitals, right? So how do I work with the other organizations that are going to provide services to me? I'm just going to give you an idea of some of the contractual models that we see. There's really two different ways you can do it, of course. One is, you know, they have the specialist, you're in a rural area, they have the providers. What we see quite frequently is contracting of services. So you basically could buy a chunk of a specialist time. And the good news is, when you look at different data across the board, is, you know, people say, does a telemedicine encounter take longer? I think what we find is when the information's there ahead of time and things are done right, some studies have even shown that you can actually, you know, do it about 2 minutes faster, right? So time it's not this big cumbersome thing that takes a lot of time. So what you can do is you contract and buy a physician's time or a clinician's or a specialist time for, let's say, 3 hours a week. And then you do the billing to get that money back, and you can charge the fees, the facility fees, everything else that you would normally charge, just as if the physician was in the location with you, okay? But you contract. And we see a lot of that going on. The other way that you could do it, of course, based on the relationship, is the physician could just bill for their services. We talked about Medicare. You use a point of service, like a GT modifier. You use a point of service, a POS code for Medicare. Medicaid has their own specific criteria, and then there's specific CPT codes, right? And I can share all that information with you, or we have the resource center that has that stuff. I say they have that down cold. They live and breathe this stuff. The other piece I think that's quite interesting is, so that's one thing from, so for you that are rural, if you think, hey, what are the business models look like? How are people arranging these things? Like I say, contract, sometimes they contract services, they buy blocks of time, they do the billing. And a lot of times that's a lot more attractive to the specialists, which are the ones that are often hard to get, especially if it's a new service and something they're not already doing, because that helps provide them a little bit of safety on their end where they're not putting out all the risks. Because if you don't fill up their calendar during those 3 or 4 hours, and they can fill up their calendar in person in their own facility in the bigger center where there's more of a volume of patients, then they're safer not to lose revenue, or the hospital's safer not to lose revenue, right? So that's one thing. The other thing is the different forms of care. And I get asked this question quite a bit, and this is interesting for our rural healthcare folks here. There's 2 different ways you can do it, right? That you can either have a specialist come in, they can provide direct care where they see the patient. And of course, rural facilities love this, especially like with mental health and even some of the other specialties, more complex patients, is they provide direct care. The patient comes in, they see the patient, they manage the patient, they schedule a next appointment in coordination with the rural facility. Either they come in or they do it, and then they order the labs, they do everything, and they basically just keep the primary care physician in the loop. The other way that you can do it is basically consultative care, which is a growing model, because a lot of these resources, these specialists that we need and want, right now in these very rural areas, primary care doctors are already managing these complex patients, as a lot of you folks are dealing with right now. As we speak, you're dealing with this right now. So the question is is how can we utilize that valuable specialty resource, but also make it where we can support the primary care doctor in these rural areas, which a lot of you are in. And the way that they do that is they do it on a consultative basis. So they see the patient. They sometimes the primary care doctor can walk in the last 5 or 10 minutes of the consult if they want to talk to the specialist on what the plan of care is, or the specialist basically writes a consult note, gives it to the primary care doctor, and the primary care doctor provides the direct care, but have policies in place that dictate that of course the primary care doctor has direct contact. It can contact and they get the support from the specialist because, as we get with some of these complex medications, some of the examples I've been involved in personally in Maine, like with psychotropic meds and stuff, they need that support and to be able to get that from the clinician. So that concludes my presentation. Before we go to questions, to see if you have any, Ron Emerson, I'm the Global Director of Strategic Partner Development, and happy to help. We have the Telehealth Resource Center. These folks do an amazing job. I was involved in one a lot of years ago. They have great resources from a lot of the things we talked about. If you have any questions for me, regulatory policy, models, technology, happy to help any way that we can. So thank you for your time, and I'll conclude my presentation there. And Allie, we can take questions if there are any.
Sure, I appreciate your time today, Ron. This is really, really informative presentation. If anybody has any questions, you are free now to unmute your lines or use the chat function to send questions in. You can see in the chat function, I have sent a link out to everybody. This is a survey that takes less than a minute to complete, and the collection of this data is very important for us to be able to continue having these free presentations for everyone. And in the meantime, if you could, just everybody take a quick second to use that chat function to send me, and you don't have to send it to everyone. You can just select Allie Orwig. I should be listed as the host. And send me a quick chat letting me know what facility you or your team are attending on behalf of. That's another piece of the data that we do need to collect to be able to continue having these free lunch and learns. And then, of course, any questions for Ron? We've got a little bit of time here before 1 o'clock. Feel free to chat or unmute your line and speak those in now.
Any questions across the board? Regulatory, policy, technology?
You've covered everything, apparently, Ron. Nobody has any questions.
Anne says she cannot use chat. Anne, do you want to just unmute your microphone and ask the question? Anne, oh, there you go. Can an originating site provider and distant provider get paid? That's a good question. No, that's okay. That's a good question. Yeah, so, something that was, so it depends. So basically, what you're talking about is the prohibition of same-day follow-up, right? And Medicare, just as if in your traditional practice, and I know what you're getting at, what about when they do a consultative? So the way that generally works, and that I've seen it work, and I've never seen anybody get kicked back on it, just like if you saw a patient in person and it was a consultation, just like in your office, right, or in a facility. If let's say an ENT did a consult, but it was consultative, and then the primary care doctor was going to carry out the plan of care, the reality is that no one would have an issue with it, right, because it's basically following that consultation and plan of care. So Medicare, years back when we had these discussions with them, when I was on the policy committee, they had basically waived the prohibition of same-day follow-up so that you could basically, if it was a consultative session, basically carry out the specialist physician's orders on the same day. And I've never seen any issues. I've never seen anyone get called back on that. So the answer is yes, just as in typical kind of day-to-day practice, there's no actual policies that I've ever seen. And if anyone else chimes in that's seen something, and I've never seen anyone get called on that or get rejected payment for it. So the answer is yes, that you can do that. If it's a consult. It can't be direct care for that same thing, of course, just kind of common sense there, but that. So does that answer your question, Ann? I know you can unmute and you can only type. Does that help?
Hi, this is Anne Marie. Can you hear me?
I can hear you. Yeah, thank you.
Okay, great. Thank you. I have a couple questions. Do you know the approximate cost of the telemedicine cart?
Yeah, it really, I mean, it can depend dramatically. You know, I can just, of course, the thing that I'm most familiar with is my company and the company that I work with. But if you want like a primary care kit, which is a cart, which has monitors, it has the video built into it, so the video conferencing, and it has a multi-purpose scope where you can look in an ear. You could like have a handheld camera, you could look in the throat, it would have a dermoscope, and it would have heart and lung sounds. It would have software in it that would enable you to basically transfer documentation back and forth for telehealth. End user cost, and this is just an estimate, is they're right around $20,000 would be a solid price and a fair price. That's for a primary care kit. Then if you want to add additional things on like spirometry, primary care. Now, there are other ways that you can get less expensive if you choose, you know, if you don't want the full cart and all those things, you can go down from there. But that's basically for a primary care kit, a cart that's all integrated, fully ready to go, and kind of like I showed the picture. Okay.
Okay, great. I do have another question. When you talk about the member being at home using an application, and you said the CMS guidelines are in the legislation right now, is that going to be for 2019?
It is.
They're going to approve that?
Well, we hope they're going to approve it. It's proposed legislation. It's proposed legislation to expand. So we're hoping that they do approve it. So that would be 2019. So we need to keep an eye on that. But the good thing, though, is it shows that we realize that, you know, these increased touch points to decrease, like I said, 71% of a lot that are unnecessary, that it's on the radar. So that is a 2019 activity, yes.
Okay, great. And will the PowerPoint be available to us?
Ma'am, I'm happy to send it to Allie, and whoever wants it, you have it. That's fine.
Okay, wonderful. Thank you so much.
Yeah, we've actually recorded today's presentation as well, and it will be available for a period of time on our YouTube channel. So you can actually get the slides from the recording as well as the presentation itself. So that will be made available. If anybody needs that, I will share my email address here in the chat function right now, and you can contact me that way. And then also we had another question come in. What kind of training does a physician need to undergo to become prepared to practice via telemedicine?
No, that's you know, it's changed a lot. So the technology it's very intuitive these days. The technology's it's very easy. You know, the biggest thing is, you know, you have the nurse on the other side. And like I said, there's different types of telemedicine. What we find is that, you know, physicians, it's very natural to them. You know, with technology now, the physician can basically control what devices they want to use on the other end. They don't have to rely on the nurse to do that. They can pick, so the nurse's hands are free to do what they should be doing, right? Is I want this. They can see the, you know, when they're listening to heart and lung sounds, they can say, okay, I want to listen to S1, S2. You know, I want to put it a little lower, okay, a little more to the left. So there's a lot of things that we can do with the technology now. So the training, to be quite honest with you, has actually been very, very minimal, and it becomes very natural for clinicians when they're using the right technology that can easily send these things through. So it's actually been quite minimal. We realize at the end of the day, you know, we talk about patient satisfaction and physician satisfaction. If you don't have an easy workflow that mimics what clinicians are doing on their day-to-day basis, you're going to lose them, and it's not going to work, and you're not going to have productivity. And they need to know that they can provide high quality care, and the technology is there. If you sell the technology, you'd understand it's very intuitive. So, but that's a great question. It's very, very minimal. Any other questions?
Okay, any other questions?
All right, and if you folks want to email me direct, we didn't talk about the PowerPoint, but if you just want to email me direct, I'll send the PowerPoint directly to you. And just a huge thank you to everyone for taking time out of your busy schedules. I really appreciate it, and have a great rest of the day. And thank you, Allie.
Thank you, Ron. Very, very excellent presentation. Thank you, everyone, for attending. Have a good day.
Thank you.
Thank you, folks. Bye-bye.